Bismillah ar-Rahman Rahim. Assalamu alaikum. I'm extremely sorry for not being able to attend this symposium in person. Reason is my illness. Therefore, I am recording my lecture so the layout and theme of the conference is not affected. Bismillah ar-Rahman Rahim. First of all, let me pay my thanks to Professor Dr. Mahmood Aurangzeb, Patron-in-Chief, Chairperson Surgery, Professor Dr. Mahmunir, Head of Department Surgical C Ward, Professor Dr. Mushtaq Ahmed, and Program Director, Dr. Muhammad Siddiq, for inviting me to the first hepatobiliary symposium, Khyber Medical College and Khyber Teaching Hospital. Pancreatitis uncovered medical, surgical, and endoscopic strategies. I must say it's an excellent scientific program, starting from the acute pancreatitis, then discussion on recurrent acute pancreatitis, then its etiology, and then the management of chronic pancreatitis different ways. The assignment given to me is the recurrent acute pancreatitis, understanding causes, diagnosis, and management. Focus areas for today. I shall discuss briefly the definition and significance of recurrent acute pancreatitis. Then we will see the pathophysiology, then the etiology, the clinical features, diagnostic workup, management, and then complications and prognosis. Normal pancreas at risk, then acute pancreatitis, recurrent acute pancreatitis, chronic pancreatitis characterized by fibrosis, pain, and diabetes, and pancreatic cancer. These are not separate diseases, it's a whole spectrum. The acute pancreatitis, the recurrent acute pancreatitis, these are the reversible stages. And we can prevent progression into the chronic pancreatitis. In my talk today, I'll mainly focus upon how we can intervene in the recurrent acute pancreatitis stage, prevent its progression into the chronic pancreatitis. The definition of recurrent acute pancreatitis. The term recurrent acute pancreatitis first appeared in the literature in 1948. Alternative terms such as relapsing acute pancreatitis have been used in the literature and textbooks in the past. Recurrent acute pancreatitis is defined as the presence of at least two separate documented episodes of pancreatitis with a period of resolution in between and the absence of definitive changes of chronic pancreatitis. Dr. Fakhr Alam discussed the management of acute pancreatitis. It may be the index acute pancreatitis or it may be the second episode of the recurrent acute pancreatitis. So the recurrent acute pancreatitis is, there is the clinical scenario of acute pancreatitis, then it resolves, no residual change is there, then another episode, then another episode. This is a very important diagram. The first incidence of acute pancreatitis. At times, it may be sentinel acute pancreatitis, characterized by macrophage infiltration, fibrosis, and morphologic changes, leading to early chronic pancreatitis. Then there is exocrine and islet dysfunction, pathologic pain and metaplasia, and the chronic pancreatitis. So the journey from first incidence of acute pancreatitis may go through this route. But this is not as common as the recurrent acute pancreatitis way. After the first incidence of acute pancreatitis, there is the first episode of recurrent acute pancreatitis, and it can lead to persistent inflammation, leading to early chronic pancreatitis and the chronic pancreatitis. Or it can go persisting new insults and triggers and recurrence and resolution of inflammation, and again the subsequent episodes of recurrent acute pancreatitis. So the common route is this one. And it can be that the first episode of acute pancreatitis leads to chronic pancreatitis over time. This is very important to understand. The first acute pancreatitis episodes, in 79% of cases, there is no further episodes during follow-ups. It is in 21% cases which are characterized by recurrent acute pancreatitis. And out of these 21%, 13%, there is no progression to chronic pancreatitis during follow-up. And 8% of this 21, they develop chronic pancreatitis. This is the natural course of acute pancreatitis leading to the chronic. Who are at the risk of recurrent acute pancreatitis? When a patient presents with acute pancreatitis, if these are young males or patients with recurrent acute pancreatitis, they are more likely to have had severe or complicated disease during the index episodes with prolonged elevation of serum amylase and lipase. And third one is more than 4 episodes of recurrent acute pancreatitis, idiopathic pancreatitis, BMI less than 25, and pseudocysts. They are independent risk factors for progression to chronic pancreatitis. So when a patient comes to you with acute pancreatitis, if they are young, they are male, if they have got severe disease and prolonged elevation of amylase and lipase, then this is the one who will proceed to chronic pancreatitis. And if you are dealing with recurrent acute pancreatitis and the 4 episodes have happened, then again, this is a high risk that the chronic pancreatitis is going to happen. What is the significance of recurrent acute pancreatitis? Identifying and treating the cause of recurrent acute pancreatitis is of utmost importance. The recurrent acute pancreatitis represents a disease state where the underlying pancreatic inflammation is still potentially reversible. And this is the point. And therefore, increased awareness of identifying and treating these conditions can potentially avoid progression to chronic pancreatitis. This is again another diagrammatic representation how they happen. The initial attack of acute pancreatitis, and when there is recurrent attacks of acute pancreatitis, initially the convalescence period 3 to 6 months, there's impaired exocrine function, and the late consequences is glucose intolerance, diabetes, pseudocysts, and development of the chronic pancreatitis. Therefore, I said that these are not separate diseases, it's a spectrum of the same disease. This is very important. In this study, these are the acute pancreatitis first episode, and none of them they progress to chronic pancreatitis. With the first attack of recurrent acute pancreatitis, 1% of these they progress to chronic pancreatitis. The second attack, 16%. The third attack, third recurrent or the fourth acute pancreatitis attack, 50% of them, they develop chronic pancreatitis. And the fourth attack of recurrent acute pancreatitis, are the fifth one in total. 47% they develop chronic pancreatitis. So as I said, higher the number of attacks, higher is the chance of these patients to progress into chronic pancreatitis. What about the etiology of recurrent acute pancreatitis? The alcohol, just like the acute pancreatitis, the chronic alcohol use is a major risk factor, can lead to oxidative stress and inflammation. Gallstones, biliary disease, small stones of macrolithiasis may intermittently block the pancreatic duct or ampulla of Vater. This is the commonest cause here in our setup. Then the hypertriglyceridemia, another common cause here. When the level is more than 1000, they can trigger pancreatitis by causing free fatty acid damage to the pancreas. Autoimmune pancreatitis, the Shah Yusuf will be talking on it. So IgG4 associated disease presenting with recurrent episodes of acute pancreatitis. Then the drugs and toxins, different drugs like azathioprine, valproate, tetracyclines, they can cause the recurrent acute pancreatitis. Infections, viral infections, mumps, Coxsackie can trigger pancreatitis. The sphincter of Oddi dysfunction, then the pancreatic divisum, and genetic factors, different genetic mutations, and of course the idiopathic. 20 to 30% of cases have no identifiable cause. In our setup, what we see, this is the biliary cause, and this is the idiopathic, and then comes the other ones. Clinical features, types. One is symptoms during episodes, severe epigastric pain, radiating to bake, nausea, vomiting, and transient elevations of pancreatic enzymes, amylase and lipase, and interval symptoms are typically asymptomatic or mild abdominal discomfort. As well explained by the Fakhri Alam, every pancreatitis episodes, the acute pancreatitis episodes, has got two phases, the early phase, the first week, and the late phase after the first week. And the severity is classified into three: mild, moderate, severe. Mild is when there is no organ failure. Moderate is when there's organ failure for less than 48 hours. And severe when the organ failure persists longer than 48 hours. And there are two types, edematous and necrotizing. And the complications within 4 weeks, acute peripancreatic collection, and after 4 weeks is pseudocysts. And in the necrotizing, within 4 weeks, acute necrotic collection, and after 4 weeks, walled off necrosis. So the same picture, this first, second, or third episode of the acute pancreatitis will be characterized by these. What about the diagnostic workups? Laboratory tests, amylase and lipase, lipid profile, calcium levels, the IgG4 levels to investigate autoimmune causes, and then in the imaging, the ultrasound detects gallstones or bile duct obstruction, the CT scan, which identifies pancreatic inflammation, edema, and pseudocysts, the MRCP or ERCP, which evaluates ductal anomaly and identifies obstructions, endoscopic ultrasound, highly sensitive for microlithiasis or structural abnormalities, and lastly, the specialized tests like genetic testing in select cases where they are young and there is a family history of pancreatitis. And of course, the best approach will be when there is a diagnosis of recurrent pancreatitis, the primary evaluation is detailed history and examination and basic investigation. And when having the detailed history and investigation, when the cause of recurrent acute pancreatitis is found, then treat the cause, and it decrease the risk of progression into chronic pancreatitis. If the no cause can be found, then the secondary evaluation is done in terms of the advanced testing. And if the cause is found, proceed accordingly. If no cause is found, then tertiary evaluation is important. So the workup is done, all the workup is not done in the same flow, it is done in the phases. What about the management? The goals of the management is to prevent recurrence, address underlying cause, and avoid progression to chronic pancreatitis and complications. Acute episode, pain management, hydration, enzymes, supplementation if needed, other standard of care treatment protocol. The underlying causes, it is very important. Unless you treat the underlying cause, you cannot prevent the future episodes of recurrent acute pancreatitis. The gallstones cholecystectomy is done. For hypertriglyceridemia, lipid-lowering therapy is warranted. For autoimmune pancreatitis, steroids, ERCP. For stone extraction, stenting, or sphincterotomy. For biliary obstruction, or sphincter aphoidite dysfunction, and pancreas divisum. And in severe or refractory cases, surgery, for example, pancreatic resection, may be considered. The lifestyle changes are very, very important. Alcohol abstinence and counseling is important. And of course, low-fat diet should be used by these patients. What are the complications of recurrent acute pancreatitis? Of course, pancreatic pseudocysts, chronic pancreatitis. And this is the only aim that we want to prevent progression into chronic pancreatitis, diabetes mellitus, endocrine insufficiency, pancreatic exocrine insufficiency, malabsorption, and of course, rarely progression to pancreatic cancer. The prognosis, the favorable outcomes are with early diagnosis and treatment of underlying cause, and the risks, repeated episodes increase the likelihood of chronic pancreatitis and long-term complication. And I showed you the study where the 4th episodes and 5th episodes, they were maximally progressing into chronic pancreatitis. So key takeaways: accurate diagnosis. It's essential to identify underlying causes of recurrent acute pancreatitis. The early intervention is very, very important, and it prevents recurrence and complications. And of course, the multidisciplinary approach. This is the need of the time for dealing with such patients, and it improves long-term outcomes. So once again, I pay thanks to the organizers of this symposium, and best of luck for the rest of the symposium. I'm sorry I couldn't attend this physically because of my illness. You can scan this barcode, and this presentation will be available on my YouTube channel, so you can see that. You can download with you. And I'm really thank you for giving me the opportunity to participate in this symposium as a faculty. Thank you very much.